Welcome to On Call with Connecticut Physicians, the Medical Society's podcast initiative. Afternoon. We all appreciate the time you're putting in today to hear from us. We appreciate the fact that the press is a big piece of our communication with our patient populations and the citizens of Connecticut as we go forward. With me today is the president of the State Medical Society, Dr. David Haas, a gastroenterologist from the New Haven area, Dr. David Emmel, an ophthalmologist from the Hartford area, and Lane Gakos, attorney Lane Gakos, who is the CEO of the Connecticut State Medical Society. Just so you get a feel for it, the Connecticut State Medical Society is 4,000 members in the state of Connecticut. It's made up of all specialties. All the hospitals in the state and all the counties in the state are represented by our physician population. So not to take too much more time, we're going to jump right into it. Our first speaker will be Dr. David Emmel, speaking on the problems we're having with pre-authorizations. David?
Thank you, Bob. Connecticut has a huge problem retaining and recruiting young physicians, and we also have an aging physician population that is suffering hugely from burnout, and a lot of the burnout problem is caused by administrative burdens. The chief of these administrative burdens is prior authorization, a procedure that was originally instituted by insurance companies specifically for hospital admissions, but has been expanded broadly and to idiosyncratically in some ways to general medical practices, all medical practices, surgical procedures, medications, in a way that's encumbered practices enormously, requiring long hours on the part of staff, the hiring of additional personnel to perform these functions, and a lot of time devoted by physicians to the process, which takes away from their time with patients. Part of this problem also interferes, and in part this problem also interferes with the patient-physician relationship, because in the delay of care, which often amounts to denied care, patients are confused and frustrated because their doctor has told them this is how we're going to solve your healthcare problem. And suddenly the insurance industry has inserted themselves in the process saying, wait a minute, maybe not. That destroys trust and is detrimental to the physician-patient relationship. One of the problems we have with it is that there's no uniformity in the process. There are many different procedures that are covered, and then they change on a year-by-year basis. So practices never know what things they have to get prior authorization for, sometimes being surprised and having to backtrack. The processes themselves are not uniform, requiring sometimes faxes, sometimes electronic, sometimes long telephonic communications. We're often faced with odd situations where we're presumably talking peer-to-peer, but the reality is it might be an obstetrician gynecologist talking to a dermatologist, and that makes issues hard to resolve when it's prior authorization. We sometimes have multiple departments in insurance companies determining whether prior authorization is appropriate. So a practice can have a yes on a prior authorization and then have another department essentially say, no, they shouldn't have been prior authorized. And now the patient and physician are on the hook for having performed a procedure that wasn't covered. When we surveyed our respondents, we found that the vast majority in an AMA poll, 93% of respondents reported that prior authorization requirements created delays in accessing necessary care. 82% of physicians reported that prior authorization can lead to patients abandoning care. And 34% of respondents reported that serious adverse medical events occurred as a consequence of these delays. This is not an insignificant problem for our physicians and their practices. As part of the solution, we have proposed a number of options that the state can pursue. Other states have created what's called a gold card concept, where a physician who achieves 90% compliance with prior authorization gets a 6-month waiver. And we're asking the legislature to move forward on this as part of Connecticut's package. We would like the standards to be unified so that the processes are clear and straightforward. We would like the insurers to create a 24/7, 365-day-a-year process so that prior authorizations can be performed when the events occur. Physicians, after all, we're 24/7, 365. The insurance industry should be. So far, they have the capabilities to do it. They should be expected to do it. We would like the technology to be modernized so that it can all be done electronically. We are living in the 21st century. And specifically, we would like the discharge process from hospitals to be designed so that patients don't have to spend a whole weekend waiting to be prior approved for referral to a nursing home or other long care facility. That's basically what I have. If anyone wants to add to that, that's fine.
My fault. I forgot to unmute myself. Thank you, David. We're going to move on to Dr. Haas, who has our last two topics that are our highest priority. David?
Thanks so much, Bob, and thanks everybody for attending today. Really appreciate your time and your interest. The first topic that I'm going to discuss are the current state Medicaid rates. We've seen true stagnation of Medicaid rates since roughly 2007. There has been virtually, with rare exception, no increase in Medicaid reimbursement for providers that are serving this very deserving and needy population. Unfortunately, as a result of that, we're seeing an increased number of providers no longer accept Medicaid patients. And what's then resulting is that there's a lack of access to care for a truly needing population in our state that have a tremendous amount of social determinants that sometimes delays their care and that leads to more significant disease and results in them utilizing emergency rooms and urgent care centers a lot more frequently. This in turn drives the cost up of healthcare tremendously within our state. And more importantly, it doesn't allow for preventative care to be taken in a timely manner so that patients present with much worse disease than they ordinarily would if they had had access to a care provider sooner. We're really proposing that the state look very carefully this year. We feel that this is the year to do it, to make some changes to the Medicaid rates and hopefully make it so that it would be on par with Medicare rates as a baseline by which to measure, at least it's an initial starting point, so that we can take care of this very, very deserving population, and more providers who really want to take care of the Medicaid population can do it at a rate at which they're not actually paying to take care of the patient populations. The current rates have paled in comparison to inflation, and currently for most providers, it's costing them money to see the patients as opposed to just being able to break even to see those patients with the resources that are necessary. So the state really should take a hard look at this so that we can continue to offer services to the Medicaid population so that access can be a priority this year and for years to come. This also would be a nice way to help retain young, talented physicians and established physicians within our state who very much want to serve that population. And Connecticut can really distinguish itself from its neighbors if we're able to do that, which segues into my next topic of recruitment and retention of physicians. As Dr. Emmel eloquently stated, we have a physician crisis going on in the state of Connecticut. We have an aging physician population. We have a real difficult time recruiting physicians to our state and keeping physicians in the state. Connecticut currently ranks 47th of 50, or 52 if you include U.S. territories, in its ability to retain physicians that we train. We do a heck of a great job of training medical students, residents, interns, and fellows, but then they all leave, and they leave because of the cost of living and the expensive cost of living in the state of Connecticut, and also the fact that many of them have significant debt from medical training. And if we could find a way in the state of Connecticut to really make it so that Connecticut is an attractive place to practice, that would be tremendous. One of the ways we can do that as I just mentioned, is by increasing Medicaid reimbursement rates. We can also, as was mentioned previously, the state legislature last year allocated $1.6 million of funds that were appropriated for state loan repayment. The average medical student will graduate with over $200,000 of debt. So it would be wonderful to have a larger repository of funds so that medical students can have some of that debt eliminated and relieved so that they can practice in our state if we could find loan repayment programs that would be attractive to keep people here. Other ideas would include medical liability insurance reform. Connecticut is not a particularly doctor-friendly state when it comes to medical liability, and it would be wonderful to make it so that Connecticut is a place where physicians don't have to practice defensive medicine, can do what they need to do, take care of patients, and focus on the clinical care, as opposed to worrying about things like pretrial judgments placed on personal property and things of that nature, which has happened within our state. The other thing is that we need to recognize that tomorrow being Women in Medicine Day, February 3rd, more and more women are entering our field. And if we can find a way to recognize these talented young individuals that are in our field and make it so that there is true equity within gender in terms of leadership positions, in terms of salaries, that also would help to promote Connecticut as a wonderful place to practice for young physicians and trainees. Bob, that's all I have.
Thank you, David. So now I'd like to open it up to questions, either about these three topics or anything else that's of interest to the press.
Our first, Jenna Carlesso from Connecticut Mirror, you've got the floor.
Hey there. You mentioned fewer providers taking Medicaid. Could you expand on that? Is that primary care providers, specialists? What are you guys seeing?
I could take that one. I could certainly submit to you, Jenna, thanks for that question, that it is really across the board. One of the biggest problems we have, and although it's been addressed to a small extent, is behavioral health. It is virtually impossible to find behavioral health providers to care for the Medicaid populations. In terms of specialties, I can submit as a gastroenterologist, which is a medical subspecialty, that there are very few Medicaid accepting gastroenterology practices in the state of Connecticut, short of the hospital clinics, which frequently have a 6 to 9 to 12 month waiting list for patients to get in. So if a patient has an acute issue that needs follow-up, when we try to schedule them in the clinics, they theoretically can't be seen for 9 to 12 months. And yes, primary care providers are also finding it challenging to accept more and more Medicaid patients given the current rates.
Got it. Thank you. And then lastly, does when you talk about recruitment and retention of healthcare workers, do your recommendations also extend to healthcare providers in the long-term care setting? We've also seen a crisis there in providing healthcare to elderly folks and people with disabilities.
So you want me to take that one?
Yes, please.
I would say that we want to make Connecticut the best state possible to care for all of our residents. We're focusing in the State Medical Society of providing comprehensive care to all of our residents. So if we can find ways to make it palatable for long-term healthcare care providers to also be part of that, that would be wonderful. We have no problem collaborating with those populations to make sure we take care of our patients from soup to nuts.
Yeah, I think one of these issues is this health equity that keeps coming up, which is how uneven the care is sometimes in the inner cities to the rural parts of the state. So the reality of it is it has to be a team approach where we spread it out amongst the ancillary personnel and other people to work with us to be able to provide that population. One of the biggest problems, at least presently with Medicaid, is every time you see a Medicaid patient, you lose money. So you need to have a mix. You need to be able to handle these populations where they live and with a team of doctors, nurses, and other ancillary personnel. Any, Vincent, you had a question?
Our next, Vincent Gabrielle from Hearst, Connecticut Media. Vincent.
Yes. Hello. Can you hear me?
Yep.
Yes.
Okay, great. So the first item on your agenda was prior authorizations. As far as I am aware, the ramp up in prior authorizations is something that's sort of more of a recent phenomena by the insurance industry, like maybe the past 2 or 3 years or so. Am I like accurate on that, or is it something that had been something that had been confined to more specialized areas and has sort of crept into everything now?
It's been bubbling up from time to time over probably the past 10 years, but it's
Okay.
become a significant problem over the last, say, 3 years. So you're correct in your assessment.
Okay.
Yeah.
Can you, sorry, go ahead.
No, I was going to say, you have to look at the impact of it. Originally, pre-authorization started for major procedures, cardiac surgery, some of the bigger surgeries, or the cancer treatments. Now it's kind of across the board, and so there's no uniformity to it. Now it's medications. I mean, even people that take chronic meds for either diabetes or heart disease, hypertension, all those sort of things, they need to get every 6 months or yearly pre-authorizations. That's from having to do maybe 3 or 4 pre-auths a month now to doing, 10 to 15 a day for a primary care practice. So I think that's the problem. And that's why you've noticed it more over the last 3 years. They've expanded it to the point where the burden is overwhelming for the practices.
In my practice, ophthalmology, they went to almost uniform prior authorization for cataract procedures about 10 years ago, and that went on for about a year, and then it was just dropped wholesale. And I think the reason was 100% were approved, and now we're back at it. The 3 of the major insurers in Connecticut require prior authorization for almost all of the cataract procedures that are performed. My surgical coordinator, who spends about a quarter of her time doing surgical coordination and 3/4 doing prior authorization, tells me that, again, we're still doing 100%. They all go through. It just requires her to hold a phone up to her ear for hours every day to get the process through.
And I would just add to that, Vincent, that I'm a gastroenterologist, and it's standard of care at the age 45 now in this country to have a colonoscopy for colorectal cancer screening. I have a dedicated staff member that has to get prior author approval for the preparation for the colonoscopy for over 95% of patients. You can't do the procedure unless you prep someone for the procedure. So she spends 8 hours a day, 5 days a week, getting preparations approved for the procedures that are standard of care. They're approved 100% of the time, but it's just another sort of bureaucratic sort of layer that's unnecessary that could be focused on patient care. And also patients hear about this and they're calling us and they're complaining more and more about how their care is being delayed because they're waiting for the authorization. So a lot of, in our opinion, unnecessary steps when we're just trying to provide the standard of care to patients.
And it's very stressful. And when you've been diagnosed with a condition that requires some sort of medical or surgical attention, you really, it's stressful to be waiting and to be delayed. It's very hard. Anyone who's been through that can tell you that.
Yeah, I think the other thing that comes up is the patients don't get to talk to the insurance company. So when things are denied, they go back to the physician and say, well, why can't I have it? And the answer is, it's not the physician that is denying it, it's the insurance company. The insurance company has inserted us between their contracts and the patient. And it breaks down our physician-patient relationships, because now we're a quasi agent of the insurance company trying to explain to the patient why their coverage is not what they thought it was. Any other question? Go ahead, Vincent.
Yeah, you've answered my question. You've answered one of the questions I had as a follow for the amount of time that this takes up in terms of administrative burden for you. How do you have any examples of what this does to your patients and your practices? Like, have you seen someone like it up in the ER? I see you raising your hand, so please.
Oh my goodness. How much time you got? So I will give you several examples. As recently as yesterday, I was doing procedures yesterday, and we had a woman who had been having issues with swallowing for over 6 months, where she wasn't able to swallow. We had gone through all the proper channels. They kept denying the procedure for me to do an endoscopy. And yesterday, it took me on the phone for at least 40 minutes just waiting on hold while this woman is disrobed, waiting for her procedure in a cold exam room when she can't swallow because someone wasn't reading the forms properly at the insurance company. So I had to spend another 40 minutes on the phone yesterday while the patient's waiting for her to finally get her procedure approved so we could do what's called an esophageal dilation to help her swallow. I have a number of patients with Crohn's disease and ulcerative colitis who are on medications called biologic therapies. And what the insurance companies do is they mandate prior authorizations for these medications that are rather expensive. But what now they're doing is they're asking, a lot of these patients require trials of different medications because everyone's physiology is different. So one medication may work for you, Vincent, but it may not work for me. And if you failed the medication, it doesn't make sense, correct, to keep you on a medication that's not working. Well, some of the insurance companies, when you try to prescribe medications, they want you to re-prescribe medications that have failed the patients already before they will authorize the medications that are actually helping the patients for no other reason other than the fact that the medications that have failed are less expensive, but it's not doing the patient any benefit. So what this leads to is delay in terms of the treatment of the patient, disease progression, hospitalization, possible surgery, because the patients aren't getting the medications that they need to prevent all those complications. So we use this phrase of, access delayed is access denied. Patients can't get their drug. They can't afford a $25,000 infusion. Nobody can really, right? So we can't just give them the medication while we're waiting for authorization. We have to get these things approved. And the crime of the whole thing is all we're trying to do is what's right. No one's trying to pull one over on the insurance company. We're just trying to give the patient the care that they need that's evidence-based and a standard of care.
Right. Okay. Thank you.
There are many examples of patients that run into that sort of problem where they're in the doctor's office and there's follow-up that needs to be done and you can't get it. I'll give you one example. Patient coming in for an MRI of the head. We do the examination of the brain, see something, but there's also something at the edge of the film that looks like it's in the neck. You cannot get pre-authorization while the patient's on the table to do the MRI of the neck. But other examples of women that have come in with a lump in their breast that turns out to be breast cancer, and you want to do a CT scan for metastatic disease, you have to send her out because you have to wait for the pre-auth so she can afford to have the test at a later date. So this slowing down of care and the stress on a patient when they think they have something and you know what to do next, but the insurance company's got the door blocked because of these pre-auths, that's a real problem day to day when a doctor is sitting across the desk from a patient.
In ophthalmology, our retina specialists who are treating an enormous number of people with macular degeneration who absolutely depend on these injections will have patients come in, but they can't perform the injection without a prior authorization. And that amounts to delays and all sorts of problems, especially a new patient who comes in where it's not known what the problem is. So suddenly they're on hold, maybe have to come back another day. Their disease may have progressed, and it represents a huge burden and hardship to the patients. Another area that represents a good example are patients who are in the hospital and need to be discharged to a chronic care facility of some sort, either for permanent care or for rehabilitation. And there's no ability on the part of our hospitalists to get prior authorizations for these facilities on the weekend. They have to hold onto these patients at enormous expense in the hospital, wait till Monday to get the prior authorization. That's entirely preventable.
Right. Okay. Thank you.
Any other topics you'd like to explore?
Do you have a bill you're tracking for prior authorization? Because it sounds like it's a real pain in the ass for all of you and everybody that you're treating.
Lane, you can address that.
Sorry about the
Yeah,
language.
No, that's
okay.
right. We use it every day.
We're hoping that we're going to see prior authorization reform in Senate Bill 6. There was a press conference yesterday where Senator Sayud Anwar talked about some of the insurance reforms that he's hoping to put into Senate Bill 6. So we are hoping to see language on that this year. I'm strongly hoping that it'll be bipartisan support for this this issue that just really is an access issue for patients and an impact on patient care. So yes, we are hoping to see language this year.
All right. Thank you.
Thank you. Appreciate your time.
Thanks so much.
You can listen to other episodes of On Call with Connecticut Physicians at the Connecticut State Medical Society's website, csms.org. Be sure to engage with CSMS by following us on Facebook, Twitter, and LinkedIn. We look forward to seeing you here next time.